Hello, I am Dr. Kate Ham, and I'm so excited to be sharing with you some really great information here on the implementation track. I am so excited for us to learn more about keratoconus and the transforming this clinical obstacle into an opportunity. The two people that are going to be sharing with us today is Dr. Chou. He practices in San Diego at Revision Optometry, where he directs a referral-based keratoconus clinic. He reported the first case of intact surgery for keratoconus in the US and serves as a clinical investigator for the synergized keratoconus lens prior to its FDA approval. So incredible. We also have Mary Prudden. She's the executive director for the National Keratoconus Foundation for the past 5 years. She's worked with eye and vision-related organizations in New York, Washington, and California. Well, I am so excited to learn more. So go ahead and take it away.
Thanks, Kate.
Thank you, Kate. I'm so excited to have Mary Prudden here today, and we're streaming out of my office here in San Diego. And I think for the benefit of the audience, we're going to start off. I'm going to ask Mary some questions about herself and the National Keratoconus Foundation. We basically have questions that we have for one another, and I think the banter that we'll have, many of our audience will find kind of interesting. So Mary, to start off with, tell us a little bit, what is the National Keratoconus Foundation?
Well, thanks, Brian. It's great to be here, and a great welcome to everybody who's on listening today. National Keratoconus Foundation was founded in the 1980s by families who were affected by keratoconus. They put an ad in the paper, and they sort of found each other. And they realized that there wasn't any organization offering education materials or support or understanding advocacy for this disease. They formed a 501c3 charity, and they ran it for about 30 years, advocating for more information about keratoconus. In 2014, the organization moved into University of California, Irvine, and we became part of the Department of Ophthalmology there. I'm a UC employee, and so the charity NKCF doesn't exist anymore, but it's part of an outreach program from the department.
Mm. And what is the impact of being located in an academic eye center?
Actually, it's helped us grow and expand because we have a lot more resources available than we would if we were sort of a standalone disease-related organization. At a university, I can walk down the hall and find a cornea specialist. I can, talk to experts easily. One of the nice things about being there is that we have a lot of collaborations with other academic centers and with other patient organizations. So I think that from that point of view, we've been able to sort of broaden the reach and the touch of National Keratoconus Foundation. We work with experts all over the world, actually, who sort of are in contact with us. There's one thing that I want to say that a lot of doctors are concerned about is that when we moved into UCI, it wasn't to drive traffic into the UC eye clinics. We sort of keep it separate, even though I'm located in the department. I don't tell people you've got to come here for your care. In fact, I probably go out of my way to say, it's really important for patients to find a local expert. And I think that that's something that you shouldn't be flying across the country to get your keratoconus care. You should find somebody who knows what they're doing in your community, because you're going to be interacting with them a lot. Mm-hmm. And so the idea is really we want to help people find, identify somebody who can take good care of them locally. And so even though we're within a department of ophthalmology, our mission is really to spread the word about getting out there and getting good care.
And how can the National Keratoconus Foundation help practitioners that are attending this webinar?
Okay, well, the first thing is that anybody who has any patients with keratoconus in their practice, or if they newly diagnose a patient, please send them our way. nkcf.org is our website. When people hook up with us, we send them quarterly newsletters. We have bi-monthly webinars. We have a monthly podcast. We have written materials. So these people who are new to the disease or coming in and not knowing much can really have an opportunity to learn a lot, to pick up a lot of content quickly. And I think that that's important for your patients to learn that sort of thing. Doctors who want to have some printed material in their office to share with their patients, we can send them that. We also help doctors. We had a roundtable at the Academy meeting. We have them at some of the other big meetings where practitioners who have spend a lot of their efforts working with keratoconus patients get together and share ideas, share tips, sort of talk it over. So I think that the NKCF wants to, help the public learn more about the disease, help patients and advocate for them, and help practitioners sort of do their job a little bit better.
Right. I should add that, at least for my own patients that have keratoconus, I really do enjoy directing them to the National Keratoconus Foundation, the website, as well as there's a really nice booklet which they can take home, so they don't always remember things that I tell them or my staff tells them in the office. So it's kind of a nice reference for them, and also to give to their family and friends to learn a little bit more about keratoconus, because again, it's not in the public vocabulary. And a common refrain by these patients is, their friends and family, they'll just tell them, oh, why don't you just wear glasses? Why don't you just get LASIK?
Yeah.
So
right, I do think that book sort of does. We always encourage people, share it with your employer, share it with a teacher, share it with a family member, because it does sort of explain why it isn't something that can be cured with a pair of glasses, and that there are some issues that are sort of unseen but are certainly affecting their lives.
One of the things I kind of wonder is, because keratoconus is really not in the public domain, the public vocabulary, I know that the National Keratoconus Foundation is working to raise public awareness, and also make third-party payers more aware of it. But I kind of wonder, do you ever think at some point keratoconus will become a household word that people recognize?
Well, I think people are learning that, we'll talk about this today, that, there's a lot more people with keratoconus out there. And so I think it's not sort of this, I've never heard of it, I can't pronounce it disease. It's going to come to a point where maybe everybody knows somebody who's got keratoconus, right. And it's just, how much it's affecting their life. But I think with the treatments that are coming on board and sort of the better diagnostics, we're realizing it's out there more than we thought. And whether people whether it becomes a household word like some of the others, who I guess people didn't know what presbyopia was 40 years ago, right. But now everybody's got it. So
it might take somebody like one of the Kardashians to have keratoconus.
Somebody, right. We need some more high-profile people with KC. So.
Exactly. Well, wonderful. Anything else that you feel is worth sharing about?
Yeah, there's a couple things that we're really passionate about at NKCF, and this is great to have the opportunity to do it. And the first is that Down syndrome individuals have very high prevalence of keratoconus, and some say up to about 30%. So I would ask that any doctor who's working with Special Olympics or sort of working with the Down syndrome community, keep that in mind, educate parents and caregivers about the importance to have patients screened and monitored for it. It's a population that we really want to get the word out, because they don't, the understanding of keratoconus and Down syndrome link is just not well understood by families, and so they're not getting their kids in to be tested. And the second thing is really these high risk or at-risk patients. Those are the kids who are rubbing their eyes, who you can't get a good refraction on, who maybe have family members who've got keratoconus. Those people, practitioners out there should have that red flag go up when any of these things come across their office, and sort of make a special effort to check, because we do find that if we can get these kids diagnosed and treated sooner, we're saving vision. And so, so I guess the important thing is to get the word out to the populations that are most likely to be affected by it. We're a little bit late. It happened 2 weeks ago, but every year we celebrate World KC Day, and that is on November 10th. And a lot of practices use that as an opportunity to promote the practice and promote understanding and awareness of KC. People do screenings, people might bring their patients in for special seminars and things like that. So that's something we want to help practitioners use this day as an opportunity to sort of increase awareness and to sort of show how their practice is helping to treat and promote and diagnose these patients. So that's something that November 10th every year, we try to get our doctors to do something a little bit special for World KC Day. So enough about NKCF, although nkcf.org, that's our website, and we do hope everybody sends their patients there and maybe checks in themselves. Now I've got some questions that I've got for you. And the first one, I think I know the answer to, but I still want to hear your discussion about it. Mm-hmm. My understanding is that you get about an hour or 2 hour lecture on keratoconus during optometry school. Mm-hmm. And here's this disease that, according to the textbooks, is 1 in 2,000. It's very rare. So why are we bothering to talk about it?
Right. I think that's a great question, is, why is there all this increased attention to keratoconus? You're correct. Back in the older data is about 1 in 1,800 people have keratoconus, but the more recent data, widely cited from 2017, is about 1 in 375 people have keratoconus. That was based off of a study of over 4 million people in the Netherlands. And so it's more common.
It's a big difference. Yeah.
It's a big difference. And the argument may be, as it turns out, it could be even more common than that, just because the tools for screening have improved. And, we see more patients getting diagnosed. Much of that is now being driven from laser vision correction consultations. There are a lot of individuals that have keratoconus. Their vision stinks, but they don't know why. They go in to see if they can have laser vision correction, and that's how they get diagnosed. Mm-hmm. So, but that being said, the mere fact that keratoconus is more common than previously thought does not necessarily alone justify the increased attention disproportionate to other conditions, eye conditions. So my feeling is it is garnering that attention for a couple other reasons. One is there are now compelling treatments that can actually move the needle in terms of helping these patients. Mm-hmm. From a surgical standpoint, obviously corneal cross-linking to halt or slow any progression of keratoconus. And then compelling transformative treatments for vision restoration with contact lens treatments. Mm-hmm. From hybrid to a lot of attention now to the scleral contact lenses. So other eye conditions, for example, retinitis pigmentosa, over the course of the past 2 decades, there's really not that much that has changed. But, I'll tell patients that have keratoconus often, I'll make a remark that, they are very lucky to have keratoconus today because of all the helpful treatments. Mm-hmm. Nowadays. So, and obviously these things are, now they're monetized. So whereas when I started off practicing in 1999, if a patient was diagnosed with keratoconus in a laser vision correction clinic, they were quickly shown the door because there was nothing that they could do. They wouldn't be able to, make any money off of these patients. And it was a very frustrating experience because the real alternatives at the time were penetrating keratoplasty as well as the corneal gas perm contact lenses. And nowadays these are they still have a role, but they're taking more of a legacy flavor relative to the new stuff. So here we have this transformation from kind of being a clinical frustrating obstacle to a real opportunity. So that's one part of it. But the other element is there is now medical legal liability for us as practitioners if we do not appropriately refer the patients of ours that have progressing keratoconus. And, the corneal cross-linking system, the FDA approval was April 2016. So Nowadays, it's over 96, 97% of commercial insurances, medical insurances cover the Dresden epithelium off the eye-link corneal cross-linking. So if we have a patient that sits on our watch with progressing keratoconus that is not, directed for corneal cross-linking, there can be loss of best spectacle, corrected acuity, scarring, and just damages which are directly proximate to not having had a referral for corneal cross-linking. And so increasingly, I feel that there are going to be medical legal claims in this domain. And as an example, I'm currently reviewing one of these cases. And so I think for the benefit of the audience, they need to know that because of this liability, keratoconus now deserves this additional attention.
So failure to treat or failure to refer it might become a medical complication in terms of the medical legal
right. So
necessity.
Correct. So the concept is that if there is somebody that has progressing keratoconus, any reasonably prudent practitioner in the community would make sure that this patient is referred for corneal cross-linking. Okay. That's correct.
So you said, so you've been in the keratoconus world for about 20 years, more than 20 years, really dedicating a large part of your practice to those patients. How has it changed in that? What were you offering 20 years ago? What were the diagnostic tests versus what's going on now? So you said you've seen it where it went from we can't do anything for you. So tell me what did it look like 20 years ago?
Right. Yeah, it was relatively slim pickings. Obviously, the penetrating keratoplasty, which years ago it was maybe about 20–25% of those that had keratoconus during their lifetime would end up having penetrating keratoplasty. And certainly it's a big deal to have to go through that.
Did you warn patients when they were diagnosed that was probably the end, was that was what they were going to see, or did you not sort of bring it up until you saw them going down, getting more
right?
serious?
I even today still let patients know that is a possibility in the event that the keratoconus progresses to an extent where the eye becomes so distorted and they're not able to get reasonable outcomes. But as we all know, it's a big deal to have to go through penetrating keratoplasty because the healing is protracted and it's not a cure. Half of patients that have had penetrating keratoplasty roughly still need to be on some maintenance corticosteroid to prevent rejection. And most of these patients still need rigid gas perm optics to get functional vision. So the patient concept is, oh, well, I'll just have this corneal transplant, everything will be fixed. And so it's not that simple. But also, again, the kind of corneal gas perm lens was the bread and butter treatment previously. And again, it still has a role for some keratoconic patients today, but it's taken a back seat due to some of the common features and challenges that patients have. Obviously, is ejection, displacement of the lenses, getting foreign particles. It can be an uncomfortable experience, in addition to limitations with vision with them because they often will decenter inferotemporally over the corneal apex, so patients end up looking through the peripheral optics, whereas the new hybrid scleral lenses, the patients get better quality vision because they're looking through the optical zone.
Right.
Yeah.
So here's a two-parter. One is, do you think 20 years ago you were missing patients with keratoconus because of the diagnostic tools you had available? And then second part, which I'd like you to really sort of hone in on, are sort of what are the telltale signs today as a patient sitting in your chair of keratoconus? What are you looking for? What are you seeing? What are you not seeing, kind of thing?
Right.
So
yeah, so I think all of the practitioners, including myself, unfortunately, there are cases of keratoconus that we probably miss because we don't look for it. And obviously the technology today has improved to the extent where corneal topography is more common. It's still not done across the board. We I kind of postulate in the future, if it ever will become kind of just a routine thing done just like tonometry as part of the routine exam. And, you know, there are other helpful technologies for detecting keratoconus at an earlier stage, which still have not really permeated into, you know, routine clinical practice, from wavefront aberrometry to pan-corneal pachymetry. But overall, the availability of sensitive screening and, you know, the clinicians thinking to look for keratoconus are improving. And the real goal is, you know, if you look in all the clinical textbooks on keratoconus, the clinical signs of keratoconus, they often mention Munson's sign, which is where the lower lid angulates or the corneal apex. All of these classic clinical signs like Munson's or Vogt's stria or apical scarring, they are lagging indicators of keratoconus, which means that it's been there already for a decent amount of time. So the paradigm now is to move things away from the lagging indicators to kind of the earlier indicators from, you know, changes in the corneal topography or wavefront aberrometry. You know, is there an increase in vertical coma that might be a telltale sign of keratoconus? And, you know, the real hope now is there's a lot of interest in the genomic commercially available genetic testing for keratoconus. So that's kind of where things are heading. And I think that is definitely kind of a welcome step. But those things will take some time to kind of make it into the broader masses of eye care practices. So a good question is, right now, what can us eye care practitioners do to help improve the diagnoses of keratoconus? Because we all see these patients, and in some cases they slip through the cracks, and we don't find out about it, and the patients might not find out.
Is it the refraction that just doesn't seem right? That's sort of, what's the red flag that you're gonna start thinking that keratoconus is on the table?
So there are a whole bunch of little things. I mean, they're kind of the obvious things that we hear about, from increasing astigmatism, oblique astigmatism, corneal steepening on the autokeratometry or keratometry. But there are also some more kind of finer points which I feel are very valuable, including when we're refracting patients, giving them choices, what's better, lens or 1 or 2, is we have a soft refraction endpoint where the patient's just noticeable difference, instead of being a quarter diopter, some engineers will claim they can see an 1/8 diopter step. You know, it's more of like a 1/2 to a diopter because there's more noise in the measurement. But there are other helpful things too, ranging from, if you have reduced best spectacle corrected acuity and you can't attribute it to amblyopia due to anisometropia or strabismus or whatnot, use the pinhole after you've completed the refraction. And if that improves acuity, you know that you have elevated high order aberrations. And that can be a telltale sign of keratoconus. There are a few other things too, is error messages in autorefraction, or even difficulty with getting tonometry readings. You know, tonometry readings often will come out artificially low because of the thin corneas. And so if there's a big asymmetry, like an IOP of 8 in one eye and 17 in the other, with reduced best spectacle corrected acuity in the eye with lower IOP, that's, to me, is a telltale sign. In my office, as an example, we do retinal imaging and OCT screening, OCTs across the board, and patients that have asymmetric keratoconus, the more heavily affected eye, the imaging of the retinal photograph, the blood vessels, they're blurrier, you get more noise in the OCT measurements. So any of these weird sorts of things kind of, you know, can drive the practitioner to start questioning, is it perhaps keratoconus? And in these cases, maybe order corneal topography or do that.
That's it sounds like it's a detective case to sort of put the little pieces together. So it's a little bit from here and a little bit from there. So if anybody's listening or is attending this conference and they think, well, maybe I do want to sort of bring more keratoconus, increase my footprint in the keratoconus community. I'm a little bit more interested in bringing these people into my practice. What are some of the things they should be thinking about? They should be, if they wanted to sort of either focus part of their practice or more of it on treating these patients, what are some of the issues that they should be aware of?
Yeah, I think there are practitioners now that are taking interest increasingly at specializing their practice. Part of it is driven just by economic forces of, there's increasing erosion of retail optometry with online distribution of contact lenses and glasses. So optometrists are looking at these niches of dry eye or myopia management, scleral contact lenses and whatnot. And just, in my case, I've kind of put front and center keratoconus and scleral contact lens prescribing. And I do admit, it's tough to do that because it's not just that you can say, okay, I'm going to hone in my practice and it magically appears that all these patients are going to come on in.
Yeah.
So, but the first step I really feel is looking within one's own practice, because again, there are patients that have keratoconus that remain undiagnosed in the majority of practices. So incorporating corneal topography is kind of an obvious step, and reevaluating these patients that are in custom soft toric contact lenses. Okay. Maybe they have keratoconus, and then broadening from there, moving these patients that are the low-hanging fruit that are currently wearing corneal gas perm lenses, custom toric lenses, prescribing scleral contact lenses, hybrid contact lenses for them. And once one has that kind of competency and confidence, then one can broaden and seek the external patients from the community, other eye care practitioners, stepping up the level of comfort in becoming a fellow in the Scleral Lens Education Society and becoming more involved, because only with the confidence and the credibility can you get corneal specialists in the community and other eye care practitioners to refer these patients to you. But you have to have kind of the ecosystem of having the patients. The best practice to have if one wants to develop kind of a specialty contact lens practice for irregular corneas is, in my opinion, working for a corneal specialist.
Okay. So do you think topography is sort of going to be a minimum requirement as far as bringing upping your game with the keratoconus? I mean, are there pieces of equipment, or you said having availability of fitting specialty lenses? That's, you've got to be able to do that. Is that, I mean, what are sort of the minimums? Is it as far as equipment and sort of expertise?
Yeah, I think the equipment's fairly easy because that's just money. You can just buy that. So corneal topography, having OCT to do anterior segment OCT, and then scleral prescribing sets. And, I always kind of laugh with these practitioners that want to bring in a scleral lens set. And there are some labs, there are probably 50 different scleral lens designs, and some of the labs even will complementarily give out their sets. But there's nothing more costly, in my opinion, than having a free set if it doesn't perform well. And the return on investment for purchasing one of these scleral lens sets is less than one eye for the reimbursements of a keratoconic patient getting them into it. So I think as a practitioner, one really needs to make the investment. Most of it is not so much the acquisition of the instrumentation as much as, making the educational commitment to doing it. And it's really has to come from a genuine place of interest and passion, because there are, I feel, some individuals that are getting into this space of prescribing scleral lenses merely because there's relatively high reimbursements through third party. But that I don't feel really translates well for obviously the patient, but also the long-term commitment to truly develop a successful practice.
Okay, well, now patients with keratoconus are sort of grouped into two categories, the slow progressors and the fast progressors.
Mhm.
So you've got these people who might go their whole life comfortable with lenses and sort of you're checking in on them and that sort of thing. And then there's those fast progressors who you've diagnosed them and their vision continues to change and vision gets worse, and you might have to send them off for cross-linking and other things. So when you're talking about maybe pivoting your practice or putting more of an emphasis on keratoconus management and keratoconus care, I'm wondering, as someone who maybe diagnoses a lot of keratoconus and has these patients in your practice, do you sort of set, once you've diagnosed them, sort of a worst case, well, they're all going to be fast. I'm assuming it's going to be a fast progressing person, so I'm going to bring them in right away and see if things are changing, or do you sort of work on a case by case? I guess what I'm saying is some of these patients see their doctors quite frequently, and some not so much. So how do you factor that into sort of the overall practice plans that you set up for things?
Right. Well, you bring up a great point, which is keratoconus is a continuum. You have patients that have progressing keratoconus, and those, by the time that they're diagnosed, and I would say many that are already diagnosed, their keratoconus is already stable. But as we move to more sensitive, earlier diagnosis, we run into the more progressive forms of keratoconus. Since, as we know, keratoconus usually crops up during the teenage to early 20s. Right. So overall, in my practice, most of the patients that I have that have keratoconus are referred by docs that are,
so they've already been
elsewhere.
Diagnosed. Yeah.
Correct. And but I think, the general assumption is that for a newly diagnosed keratoconus patient, especially in their teenage to early 20s, you can assume that the keratoconus is progressing at that stage. Now, for somebody that is in their 60s,
so how
or 70s,
how soon would you bring in somebody who was 19 years old, newly diagnosed? Would you want to see him in 3 more months? Or
in that specific case, I would presume that their keratoconus is already progressing and send them. I would not wait and have them have a consultation for corneal cross-linking. I think a great example is, during the COVID lockdown, practices were closed, and there were patients that were on deck to have corneal cross-linking. There was a study that was published earlier this year that found that of those patients, that they basically had to wait on average 90 days over the course of the COVID lockdown. They lost best spectacle corrected acuity, they had scarring. So for me, it's, I don't want to wait for the benefit of those patients. Now, on the other hand, if it's a newly diagnosed patient in their 70s that has keratoconus.
And that happens.
And that has happened. They've obviously have had keratoconus for a long period of time. It's just that they haven't known about it. Those are the patients that I'm certainly not as eager for them to have corneal cross-linking. And so there's that continuum. So you start thinking more about the patients in the middle.
We are getting a lot of contacts from patients who said, I'm just diagnosed because I was going in I'm getting my cataracts out. So that is an age group that for some reason is now getting diagnosed. And I think a lot of it is because of the more delicate diagnostic tools that are available now. And so these doctors are throwing out, well, you've had this eye disease probably all along and never dealt with it.
Absolutely. I mean, it's if I can interject real quick, it's very similar to, patients that are in middle age that don't have keratoconus that we get into soft contact lenses, is that only then, because they're applying or removing contacts, do they realize that they have a pinguecula, and so they're newly diagnosed and they feel that their pinguecula has suddenly appeared.
So here's the question for the people who are maybe a retail optometrist or someone who sort of says, well, this keratoconus seems like it's more work than I thought it would be. So if they do come across a patient in their practice that they believe has keratoconus, what is the referral that they make? Do they send it off to a contact lens specialist to get worked up, or do they send it off to a MD to get cross-linked? Where do you stand on that?
Right. There's no right or wrong, but
Okay.
that I'm delighted that you asked that question because it's a very important one. And many of these retail clinics, a disproportionate number of Generation Y and Z, they're going to them. These are the ones that have the more progressing keratoconus. So I've thought about this mental exercise myself. And let me give you an example which might help guide the answer, which is, I've had a keratoconus patient that is very much visually dependent on scleral contact lenses that I referred for corneal cross-linking. And this patient had a necessary contact lens authorization under IMED for steep keratometry being over 53 diopters K. That was the qualification for the necessary contact lens authorization. This patient had corneal cross-linking done, and after having it done, no longer had a steep keratometry of 53 diopters or more, lost the qualification for necessary contact lens through IMED, and was absolutely furious because now has been imposed with this tyrannical recurring burden of having to pay several $1,000s each year for having the scleral contact lens product and services. So you can, and surgeons don't know this. They don't know about the nuances of necessary contact lens authorizations, whereas I think the practitioners that prescribe contact lenses know about that. The corneal surgeons that do corneal cross-linking, I've not seen an informed consent that has had this. So I would submit that there is value in these patients that are being referred from other eye care practices to send them to a contact lens specialist that is knowledgeable about necessary contact lens authorizations, because if the patient's going to be in scleral lenses and needs corneal cross-linking, that practitioner is going to be making that referral regardless.
Okay, yeah, it's a tough question. So I think we've given a nice overview. We've got a few minutes left that I'd like to talk about some of the hot topics or some of the current things in keratoconus care and management, and just get your take on one of them. First category would be these specialty IOLs, a PRK with cross-linking, a combined procedure there. Intacs is another one. What about these sort of options that sort of in addition to the sort of the extra dressing on it? What's your feeling about those? And where do they fit?
There's definitely consumer demand, I think, amongst some that have keratoconus for some surgical cure. And there are practitioners that offer many of these procedures. What I see in my own clinical practice is many of these patients that come to me after they've had all these combined surgeries and their vision still is not up to par. The reality is none of these surgeries can smooth out the cornea to the extent of what a scleral contact lens surface can provide in terms of visual rehabilitation. And so I think that, there is kind of a level of public education that needs to be presented to these patients.
Do you tell these patients there are these options out there, or you wait for them to come? I mean, that's not something that you're out there promoting, that they go get PRK plus cross-linking or Intacs, or you just sort of wait for them to hear that from some other source, and then
there are instances where I will proactively mention these, but it becomes kind of confusing also because there's so much. But the predominant surgery at this juncture which deserves attention is obviously corneal cross-linking, which is inherently more or less a non-refractive procedure. But a lot of patients, there are some patients that get sold corneal cross-linking because they have hopes and emotions that it's going to help their vision.
Yeah, that's what a lot of them, I believe, that they'll no longer need contacts. They'll have perfect vision.
Correct.
Is what they often get told. Okay, here's another one that's out there. There's now genetic test available to determine keratoconus likelihood. Have you got any thoughts on the Avigen test? That's a cheek swab that patients can do.
Right. So that's the exciting thing, is that in the future, we can move ahead of the game and go to leading indicators of keratoconus as opposed to lagging indicators. And I do have some experience with the Avogen, which, right now is probably not the time and location to share that, but in the next issue, in January, February issue of Review of Cornea and Contact Lenses, I'm sharing some of my results with the Avogen test.
Okay.
So,
I have one more because I know we want to leave some time for questions, and that is that most of the patients that we survey from National Keratoconus, they are in GP lenses, the people who've been in them for years and years. That was the go-to when you got a diagnosis of keratoconus, you got that. We're seeing now that younger patients and patients who are first diagnosed are actually getting fitted in sclerals as sort of the first go-to. What's your feeling about GPs versus sclerals for sort of management of keratoconus?
Yeah, my first line treatment now for many is indeed the scleral contact lens. So that becomes kind of the bread and butter part of my practice. Again, that's not to say there are definitely patients out there that I still have in corneal gas perm lenses because of improved outcomes, but so much of it has moved to scleral lenses.
Okay. Well, this is our wrap up. We'll throw it back to Kate. Do you have any questions for us?
So sorry, I learned so much from y'all. I truly, the amount of information that you both have is just incredible. So we do have a question from our audience that I just wanted, that they were curious about, thinking it back to that medical legal section where we're kind of thinking about, okay, when do we refer for cross-linking? How much burden am I carrying if I'm not referring for cross-linking? When would be a good time for us to start thinking about, as a practitioner, referring for cross-linking? When does that progression hit? What does that look like when we should start thinking about referring?
Right. That's a great question. I think overall, again, if somebody has a patient that has newly diagnosed keratoconus, early to 20s, that becomes an easy decision. That's not somebody that a practitioner wants to wait and see as much as just send them for the consultation for corneal cross-linking. Obviously, for somebody that's much older, there isn't that need. It's that kind of in-between stage. It becomes a little bit trickier. And I generally like to err on the side of being conservative and making sure that those patients are referred. And I'm hoping that there's going to be more guidance coming as we have more data on corneal cross-linking and in age.
I think that's great. It's kind of a good place for us to know, when should I start at least thinking about it? When should I start making that recommendation? And knowing that since there are cases going on currently, that most likely there is going to be some new information that's coming out, and there is going to be some more guidance for us, that will come out. I had a couple of questions too. So let's say I'm do a lot of keratoconus work with keratoconus patients in my practice. How can I get involved with the Keratoconus Foundation? What are ways for optometrists or people that have a passion? I mean, I know there's some opticians, and I know there are, optometry technicians that are passionate about keratoconus. What are ways that they can get involved with the Keratoconus Foundation, or that they can show their support or do things of that nature?
Oh, wonderful question. Thanks, Kate. Certainly, we have a referral a group. We have 400 doctors who are listed on our website, and we have links to their practices. If you we're interested in that, and you met the sort of training and education guidelines that we set up, we'd love to include you. So go in there and check. We're looking for people who have had specialty, who can have sort of documented specialty training in scleral lens or in cornea and contact lens. Maybe have had a residency or a fellowship and are fellows in the Scleral Lens Society. So certainly we would welcome to include any of those people on our referral list. But we also have plenty of doctors who just have an interest in it, and they get our newsletter and they come to some of our events and that sort of thing. We're happy to send information to them for them to share with their patients. There's no cost to joining. Just give us your email and information, and we'll start sending you information and start welcoming you. So that's a great question. Thank you.
Awesome. I know a lot of times we start treating keratoconus patients because, especially, as a new practitioner, you'll have your first keratoconus patient come into the office and you were trained in school and then you're like, but what's next? Like, I'm not going to just see this patient once, like sometimes we do in school because they come in for a yearly exam or every so often. So this is a great resource for people to utilize for the long term as they grow as a keratoconus practitioner. So we are in the implementation track, as you know. What is one thing a doctor can take that has, maybe they see keratoconus patients, but they don't do a ton right now, but they want to take something back, implement on Monday to start identifying and educating people about keratoconus. So helping to identify patients, helping to educate patients about keratoconus to make it more of like a household term. What is something that a doctor can do to do that in their practice?
Yeah, within my own practice, I've looked at the points of contact, and when patients are filling out the registration form, one of the things for reason for visit, it's keratoconus. It's obviously website for practices that are motivated for using social media. Those are all avenues for letting the community know that they're involved and are open to seeing these patients. But again, the real key to having a successful practice that manages keratoconus is having the source of patients. It's kind of like, if you want to have a thriving glaucoma practice, the average age of your patient base has to be almost dead. And so in like myopia management, if you want a thriving myopia management practice, at least right now, the organic demand is in the Asian American community. So you have to have that, demographic to work with. So it doesn't do any good necessarily just to make all the promotion if you don't still have that source.
I think that's really important to realize that people with keratoconus just don't like pop up out of nowhere. There are we have some more clear avenues where people might develop or be at higher risk for keratoconus. And so it's time to tap into those communities. I know that Dr. Chou, that you work at a referral center, but so you see a lot of keratoconus patients that come in. How do they find community? Do they find community within themselves or within the larger groups of people where they can find support as they walk this journey together? And also, is there things with the Keratoconus Foundation where people that have keratoconus, where they can find support and kind of walk through this journey of keratoconus?
Yeah, that's a wonderful question. And that's actually the reason why all the patients that I see that have keratoconus, I direct them to the National Keratoconus Foundation, because, they have a very robust kind of network amongst themselves where they can communicate with one another and feel like they also have the emotional support, not just the clinical support. And maybe Mary would like to comment a little bit more on it.
We work with a few, there's a couple patient message boards that are out there that we sort of direct people to, where they can sort of share their story and maybe ask questions, where they're getting sort of feedback from people who've lived that same journey. So we do know that there is that sort of, you can't understand me if you don't have keratoconus aspect that a lot of patients have. And so we agree that may be the case. And so we direct them to some Facebook and Reddit and some groups where they can do that. From our point of view, we sort of keep things like, we want to give you up-to-date, information that you can use that can sort of help you make decisions and sort of give you guidance as far as what's the next step. But you've hit on something very important, is that that one of the problems with individuals with keratoconus is they do feel very singular, and I don't know anybody else with this disease. I don't know anybody else. One of the things that we do occasionally is have these family symposia, and we've had it at University of Houston, and our next one is going to be in May at Ohio State, where we actually bring in people in the geographic area who've got keratoconus, and they're thrilled because they're meeting people. They've never met anybody else who's had the same thing. They listen to a sort of half day of lectures, but really the networking among other patients is very helpful, and they really like that part of it. So I guess one thing I might suggest to practitioners who have keratoconus patients is to sort of ask them, there's some sort of psychological questions that, like, are you feeling anxious or depressed about your condition, and would it help to talk to somebody else? And maybe we can put them in touch with somebody who would be willing to share experiences and sort of listen. But it's there's a psychological element that sort of has to get addressed for a lot of these patients as well.
Definitely. I think it's such an important piece, is recognizing that even though they might have an eye condition, they are a whole person and they are a whole patient. And I think you both have described that and really brought that to the forefront today, that we are treating a person and we're really going to give them the best sight and vision possible. Thank you so much for being a part of this today. This was absolutely fantastic and I learned so much. Thank you so much for coming. Stay tuned. We have another presentation coming up right after this. It is called Where Good Ideas Come From, How Dompe Turns Insights into Innovation. Thank you all so much, and we look forward to seeing you soon.
Thank you.